Long case ASD, atrial septal defect. Mrs. A. Begum, 45 years old, married housewife, non-diabetic, normotensive, non-smoker, hailing from Tajpur, Sylhet, was admitted into this hospital on 10th August 2022 at 11 a.m. through outpatient department with the complaints of increased shortness of breath for 1 month and increased palpitation for 1 month. According to the patient's statement, she was reasonably well 3 years back. Then she noticed shortness of breath during heavy exertion like carrying pot of water from pond, washing clothes, doing household works hurriedly, and it was relieved by taking rest for a while. This shortness of breath is progressively increasing in nature. Now her shortness of breath has got worse for last 1 month, which occurs during mild exertion such as doing daily activities like walking at home, bathing and dressing. Now it needs prolonged rest for improving her shortness of breath. She has no history of sudden awakening from sleep at midnight due to breathlessness and has no history of difficulty in breathing during lying flat. Her shortness of breath is not associated with exposure to cold, dust, fumes, and allergens, taking drugs or food, fever, cough, coughing out of blood, bluish discoloration of tongue, fingers, or skin. It is not associated with swelling of leg, abdomen, or face, decreased urine output, and there is no diurnal or seasonal variation. She has also complained of palpitation for last 2 years, which she feels regular in nature. Initially, it occurred with moderate to severe exertion and was relieved by taking rest for a few minutes. The frequency of this palpitation is progressively increasing in nature. For last 1 month, it occurs even with mild exertion and takes prolonged time to be relieved. This palpitation is not associated with taking tea or coffee, anxiety, depression, chest pain, dizziness, lightheadedness, transient loss of consciousness, increased frequency of micturition, vertigo or vomiting, weight loss or loose motion, and increased sweating, hand tremor, or heat intolerance. She denies any complaint regarding hoarseness of voice, difficulty in swallowing, focal weakness of any side of her body, or any unexplained fever, skin rash, joint swelling, joint pain. On query, she gives history of recurrent respiratory tract infection in her childhood for which she had to take some drugs like antibiotics from local physicians. She had no history of significant sore throat, fever with joint pain and swelling during her childhood, which is suggestive for rheumatic fever. She has no history of known ischemic or hypertensive heart disease, diabetes mellitus, asthma, COPD, tuberculosis, or contact with known TB patient and documented COVID-19 infection. Her bowel and bladder habit is normal. With this complaint, she had consulted with several physicians and taken several drugs irregularly, but she could not mention the name of her disease or drugs. She had never admitted in any hospital for her illness and she had never undergone any invasive procedures or any blood transfusions. With this complaint, she had admitted into our hospital for better management. She is married for 25 years and has 4 children. Age of her last child is 10 years. Birth history of all of her children was uneventful and all were delivered by normal vaginal delivery in local Upazila hospital. Her menstrual cycle is regular with normal cycle and normal in amount. Her husband uses barrier method for contraception. She was immunized as per the then government vaccination schedule and has got all doses of COVID-19 vaccination also. She is non-smoker, non-alcoholic, not betel nut chewer. She lives with her husband, has 4 children, she has 4 siblings, and her parents are alive, and none of them have any similar type of illness. There is no family history of sudden cardiac death. She has come from low socio-economic condition. Her husband is a farmer and only earning member of her family. On general examination, patient is looking ill. Body weight average, cooperative, decubitus anchois, pulse is 110 beat per minute. Regular in nature, normal in volume, no radioradial or radiofemoral delay. Condition of the vessel wall is normal. All peripheral pulses are present and symmetrically palpable. Blood pressure is 110/70 mm mercury. In both arms, there is no postural drop. JPP is raised 6 cm from sternal angle and a wave is prominent. Respiratory rate is 18 breaths per minute and normal in character. Temperature is normal and periphery is warm. Patient is non-anemic, non-icteric, non-cyanosed, non-dehydrated. Leg edema and sacral edema is absent. There is no clubbing, leukonychia or chylonychia. There is no thyromegaly or lymphadenopathy. Hair and skin condition is normal. There is an IV cannula in situ in left forearm. On precordial examination, as far as I expose my patient, apical impulse is not visible. It seems to be there is no chest wall deformity. Size and shape of the chest is normal and there is no visible scar mark as far as I expose. There is presence of epigastric pulsation, but there are no visible suprasternal and supraclavicular pulsations. Apex beat is located in left fifth intercostal space, just medial to the left midclavicular line, 9 cm from midline. Size and character of apex beat is normal. Left parasternal hip, palpable P2 and epigastric pulsation is present. First heart sound is normal. Pulmonary component of second heart sound is loud in pulmonary area. There is presence of wide and fixed splitting of second heart sound, which is evidenced by no change with respiration and change of posture. There is an ejection systolic murmur heard over the left second intercostal space, that is pulmonary area, grade 3/6 in intensity with no radiation. Best heard with the patient in sitting and leaning forward position with breath hold after inspiration with the diaphragm of the stethoscope. Lung bases are clear. Other systemic examination reveals normal. This is all about the history and examination findings of my patient. So my provisional diagnosis is congenital acyanotic heart disease, most probably atrial septal defect with pulmonary hypertension with NYHA class 3. Thank you.